So I am going to cover the last part of the BDA sheet as I have covered almost everything important in my first two videos of infection control. So let's do it for today. And as you know that nothing is really important in the overview and the key learning point, just give a good read. And that's all. You don't have to remember anything related to your exam from these key learning points. So, in infection control practice and the policies and the protocols, so these are the things that need to be in the practice, and that's a very basic and common things and that we all know. So just give a good read. No, nothing related to exam on in these bullet points that I would say that you need to highlight or just remember anything from there. So possibly the only thing which is really important here is just the review your policy and procedure at least every 2 years. Number one. Number two, the audit is really important here. So there are two things which they do ask on the exam. So read the question carefully, what exactly they are asking about. So I would say again, read the question carefully before you mark any answer. So let me read these two lines for you. So the review your processes by undertaking regular audits of your decontamination processes. Okay. So review your audit for your decontamination process 6 monthly in England and Northern Ireland and at least annually in the Wales. The result of the audit and the audit you have conducted, right? So you need to retain it for 2 years. They do ask the question in every other exam. It's just like that. Either they're going to ask you for the regular audit of your decontamination process for how many months, either by giving England, Northern Ireland, or by giving a Wales for at least annually, and the result of audit should be retained for how many years? For 2 years. So just remember these two lines by heart because they are going to give this question on your exam. Okay, now the essential requirement, the best practice. That's not that important. That's what we already read it about, the washer disinfector and everything. Now the professional responsibilities is you just need to give a one read, like nothing's really important that I would say that you just memorize it. It's just like patient information. You must take a detailed medical history when the patient first attend the practice and review it at a subsequent appointments. It must be retained as a part of the patient dental records. Now, the health screening before the appointment is confirmed. New members of the clinical team should undergo clearance checks for the BBV and TB, bloodborne vaccines, and the tuberculosis. Additional checks are required for those performing exposure-prone procedures. Okay, this is it. Okay, dental nurses do not usually carry out EPPs as a part of their routine work activities and can continue working surgery if found to be infected with hepatitis B or other BBV. Okay, now here comes the important part, hepatitis B, C, HIV, what we need to remember for exam point of view. So clinicians who are hepatitis B surface antigen positive should have their HPV DNA viral load tested. Number one thing that it should be tested. If the viral load is above 200 IU per ml, they should cease EPP immediately. Okay, initial clearance to perform EPP requires two identified and validated sample taken at least 4 weeks apart, with both showing a vital load below 200 IU per ml. Now that's really important. It's like the first thing, they should have their HPV DNA viral load tested. And what is the value? So now you would see there's a contradictory values on the pink book and the values here on the BDA sheets. So what we followed for our exam was the BDA sheet, because pink book has been like a oldest version. So that's the reason what our teachers taught us, that we followed these all values. So before appearing an exam, just try to figure out which values do you need to follow. Okay, so probably if it's the viral load above 200 IU/ml, it means that the person is positive and they should cease the EPPs immediately. And it did require the two validated samples taken at least at 4 weeks apart. So that's again a good question. They do ask like how many weeks apart we can do a test or take a sample for HPV, right? So that's 4. And if the load went below 200 IU per ml, then it means that we can start working, etc. Hepatitis C. So clinicians who are HCV RNA positive should be restricted from performing EPPs. Makes sense? Clinician living with HCV who has been treated with antiviral therapy and who remain HCV RNA negative for at least 6 months after cessation of a treatment should be permitted to return to performing EPPs. A further check 3 months later should them to be HCV RNA negative. A return EPP is a local decision and does not require a referral to UKAP. Okay, that's fine. Now the first thing, that they have been treated with antiviral therapy and remain HCRNA negative for at least 6 months after the cessation of a treatment should be permitted to return back to performing EPPs. A further check 3 months later. So remember these number of months, here and here, number of weeks and months. Now the HIV clinician living in HIV who have plasma viral load above 200 copies per ml should not perform. So that's again above 200. HPV is again above 200. So initial clearance to perform will require the clinician to be an effective combination of antiretroviral therapy, to have had 2 IVS test result taken at least 12 weeks apart. For HIV, we need to take 2 samples at least 12 weeks apart, and 4 weeks apart was HPV. Now both must demonstrate a viral load below 200 copies ml. That's what we know. The consultant occupational blah blah. Okay, the clinicians who are restricted from EPPs and receiving antiretroviral therapy and with the viral load below 200 copies per ml need 1 IVS 12 to 16 weeks since their last undetectable viral load for the consultant occupational physician to grant clearance for EPPs. Okay. Now the first is at least 12 weeks apart if it's below 200 ml copies. And now another clinicians who are restricted and receiving antiretroviral with the viral load below 200 need 1 IVS 12 to 16 week since their last undetectable viral loads. Okay, that's all. Now the personal protection, that's PPE. Now the training individual decontamination infection, daily and weekly periodically test That's already decontamination, nothing that important. Now the immunization and the tuberculosis. Now the immunization for hepatitis B and TB. Okay, nothing is really important in both the paragraphs. So hepatitis B vaccination is recommended for those who have a direct contact with the patient's blood-stained body fluids, including saliva. This includes contact with blood-contaminated sharp instrument. New staff who have not been immunized should start the vaccination course. Okay, dental nurses can assist chairside. Okay, not that important, but it should be. The both of these two lines are important here. So immunization, again, infectious diseases. These include the information of hepatitis B immunization. For pre-exposure prophylaxis, an accelerated schedule should be used with the vaccine given at 0, 1 and 2 months. This is important. Mark it. This is really important. So we give a vaccine dosage at 0, 1 and 2 months. A very rapid schedule can be followed with a vaccine given at 0, 7 and 21. So an accelerated schedule is 0, 1 and 2. Very rapid, it's 0, 7 and 21. And a 4-dose administered 12 months after the first dose. That's important. Antibody titers for hepatitis B should be checked 1 to 4 months after the completion of the primary course of vaccine. Okay. The results will inform decisions about the post-exposure prophylaxis following a known as a suspected exposure to virus. Immunocompetent healthcare workers who have received a primary course of hepatitis B vaccine are known responders, no longer require a booster dose of 5 years later. Okay, to the non-responders. Okay, non-responders antibody titer below 10 MIU per ml must be tested for markers of current or past infection. A repeat course of vaccine may be required. They should be briefed on a personal risk of working in dentistry and importance of following the practice inoculation injury protocol to allow timely post-exposure prophylaxis. So the non-responders antibody titer should be below 10 MIU per ml, and that must be tested for the markers of the current or the past infection. So might they need to repeat the course. Now for TB, the TB is spread via water droplets or by direct contact and has been transmitted by dental procedures. So dental professionals are more likely than general population and a contact with the infection unvaccinated. Okay, those who are tuberculin negative and aged under 35 should be vaccinated. Those who are tuberculin negative and aged under 35 years should be vaccinated. The current shortage of BCG vaccine has interrupted the national immunization. Okay, blah. Not that important. Inoculation injuries are the most likely route of transmission of the bloodborne and viral infection. Inoculation injuries are the most likely route where contaminated objects or substance breaches in the integrity of the skin or the mucous membrane or as a contact with eyes, for example, sticking or stabbing with a used needle or other instruments, splashes with a contaminated substance of eye or other open lesion, cuts with contaminated equipment, bites and scratches. Sometimes they do give this question. So inoculation injuries must be dealt promptly and correctly, allow wound to bleed, then wash thoroughly with the running water. Assess the risk associated with the patient and injury where the transmission infection is possibility. Contact your local occupational health service for advice on necessary follow-up action, including serological surveillance and post-exposure prophylaxis. Practice without an NHS contract may need to arrange this privately. Details of your local contact should be displayed prominently within a practice. Record the incident in the accident logbook. Who was injured, where it was taken, which dentists were informed, and everything regarding that. It's not that important. The first line is really important, that allow the wound to bleed and then wash thoroughly under the running water. If the source of the patient HIV infected and the injury risk assessed as a significant PEP, should start as soon as possible and ideally within an hour of injury. You should identify the local arrangements. Okay, that's really not that important. Whatever I marked, just remember and stick to those points, and definitely you will retain all this on your exam day. So we're done from, we covered the first part, we covered the personal protection part, immunization, training in individual immunization, inoculation, hand protection, and everything. We did this. We covered this as well. Okay, so we left with the common infections. Now the herpes simplex and the influenza, and then the national quality. Okay, so common infection is the herpes simplex. HSV1 is usually associated with infections of the lips, mouth, and the face. So HSV HSV1 is usually associated with the infection of the lips, mouth, and the face. It's a common virus and usually associated with the childhood. So number one is HSV1 is associated with childhood, also that is affecting the lips, mouth, and the face. Often causes the lesions such as cold sores in around the mouth and is transmitted by the contact with the lesion and infected saliva. By adulthood, up to 90% of the individuals have antibodies to HSV. The herpes virus can reside in the body for years, appearing only as a cold sore when something provokes it, for example, illness, stress, hormonal change. Sun exposure, individuals usually experience a tenderness, tingling, and burning before the actual sore appears. Initially as a blister, which is subsequently crust over. All stages of herpes virus infection can be contagious, although fluid-filled vesicles are much more infectious than the other stages of the herpes. Ideally, dental treatment should not be undertaken. Okay, the herpes simplex virus is highly infectious and easily transmitted. Manipulation of the facial and oral tissues can exacerbate the condition and cause breakdown of the lesion and bleeding. Spread of the virus to other areas of the skin can cause significant problem in new primary lesion. For example, infection of the eyes is rare but significantly serious complication. That's not that important. Now the important points related to your exam, it's going to be in this paragraph. You need to remember all the points I have highlighted. And the patient requiring urgent dental care should not be denied it, but until the herpetic lesions are healed, the dental team should take care and prevent the spread of the virus. Now the reactivation of oral herpes can occur within 3 days of major dental treatment. Now that's really important. Reactivation of oral herpes can occur with 3 days of the major dental treatment, root canal or surgery. For example, dental treatment may also cause intraoral recurrent herpes, oral tissues, adjacent to the teeth. Children are particularly vulnerable before they develop antibodies to HSV1, and extra care must be taken to avoid spreading the virus in areas of the child mouth and face. Now, the influenza is a respiratory illness characterized by the rapid onset of a wide range of symptoms, including fever, cough, headache, sore throat, aching muscles, and joints. It has a average incubation time of 2 to 3 days, and people are the most infectious soon after they develop the symptoms. Transmission is through the close contact with an infected, coughing and sneezing, hand washing with the soap and water or alcohol hand rub, and the environmental cleaning will deactivate the virus. The main measures of containing infection, standard infection control measures, and droplet precaution, a stay at home approach, separating flu infected patients from well patients, and dental care is needed, preventing symptomatic visitors. MRSA, no additional infection control precautions are necessary for the dental treatment of patient and colonized with methicillin resistant Staphylococcus aureus. However, members of the dental team known to be colonized should not be undertake or assist any invasive procedures. So you need to remember herpes simplex details, influenza, MRSA, really important in this BDA sheet. Now the CQC, healthcare inspect, dentist and dentist providing inspections are carried out at least 3 years by an experienced HIV inspection manager and external. That's only important in this, that you need to carry out the inspection for at least 3 years. I hope you like the video. Thank you so much.